Welcome everybody. Thank you for joining tonight. The main presentation will examine the latest science and treatment options for joint conditions. Tonight's session will be limited to 60 minutes and include a Q&A segment for our panelists to answer your specific questions. The switchboard's lighting up here. We actually limited the number of registrations to 50. It's so wonderful to see such strong interest from medical specialists, doctors, allied health professionals, and scientists from all across Australia. I will be the host of tonight's event. My name is Victor Roy. I am the chairman of Celgen Medical. And I'd like to thank our sponsors, particularly Lipogems, our main sponsor, Simpler Health, and iCells Medical. To connect with us after the presentation or for further information or join our network, please go to our website and click on the contact page for further contact information. Let's take a quick look at the agenda for tonight. For the first part, we'll look at the science behind treatment options related to joint conditions. And then we'll look at the application of science resulting in improved patient outcomes. And then our panelists will answer your questions. Now, before I hand over to our guest speaker, I would like to quickly introduce our Q&A panelists. Paul Cray, who spent more than 30 years in senior exec roles at Roche Diagnostics, including Senior Vice President worldwide and Managing Director of the Australian operations for 17 years. Dean Kilby, a specialist or scientist specialising in metabolic reprogramming to reduce the risk of obesity and metabolic syndrome on joint dysfunction, and has spent many years working with doctors and scientists to improve patient outcomes. He's Director of Simpler Health and a sponsor of tonight's event. We also have Giovannino Barbiero from Lipogems, the director there, and previously a director at Smith & Nephew Orthopedics. And Raffaella is also from Lipogems, and I'd like to thank them very much for being the main sponsors tonight. It is now my privilege and great pleasure to welcome an internationally recognised expert who has published over 70 studies and is chair or director of 5 esteemed European institutions. Together with orthopedic surgeon Dr Laura De Girolamo from Israel, she is leading the ESCA Orthobiologics Initiative, and this initiative relies on a wide panel of experts from around the world, including Australia, and aims at building an educational platform through good practice guidelines to serve as a reference for this topic. And without further ado, I warmly welcome Dr. Laura De Girolamo.
Thank you very much, Victor. So I'm going to share my screen. Thank you very much. It's really a pleasure for me to be with you guys tonight. As Victor said, I'm going to present you the latest science and treatment option that Lipogems offer for joint conditions. I'm a cell biologist, PhD in pharmacology, and I'm leading the Orthopedic Biotechnology Lab at the Galeazzi Orthopedic Institute. And in 2017, we ran the Regain Center, which is the Regenerative Galeazzi Institute for Medicine. And actually, we try to combine basic science and clinical applications. So I'll do my best to share with you both the basic science features of the Lipogems treatments, but also, since you are clinicians, I'm sure you are definitely interested into the clinical application of Lipogems. So the last part of my presentation will be dedicated to the clinical findings. So when we talk about treatment option for joint conditions, we have several of them, starting from the very conservative treatments like lifestyle changes, medication, especially anti-inflammatory drugs and painkillers, physical therapy, viscous supplementation. And then if our patients do not solve the problem, the last stage is the joint replacement surgery. But there's a big void here in between these two kind of techniques. And where someone see empty space, someone else see opportunity. And I think that orthobiologics are really the opportunity in between these different stages for the treatment of joint condition. And in particular, when we talk about orthobiologics, we talk about the use of the platelet-rich plasma products, which are a really huge group of products, and the cell-based therapy. And today we are going to focus on cell-based therapy. Sometimes when we think about cell-based therapy, people think that they are a kind of magic because the methodology of the research hasn't been very accurate so far, and also because sometimes cell therapy are described as a miracle water for different applications. But actually what I want to do is to try to convince you that behind cell-based therapy, there's a really good, strong, and big science. And this is the object of my presentation today. So when we talk about cell-based reparative medicine, we see a complex scenario because we can have one-step or two-step techniques. We can use autologous cells or allogeneic cells. But in any case, the most used cells for cell-based reparative medicine are the MSCs, the mesenchymal stem cells. The mesenchymal stem cells were indeed, sorry, I just wanted to close this window. Okay. The mesenchymal stem cells were called like that because for mesenchymal, for their ability to differentiate into mesenchymal type cells, and also stem or stromal, because they appear to arise from the stroma, so from the complex array of supporting structure. And we should remember that back to the 70s with Professor Friedestein, and back to the 80s with Professor Kaplan, these cells were firstly found and isolated from the bone marrow. These cells were described as cells able to adhere to the plastic in culture, to grow in culture, so to proliferate, to express specific cell markers like CD73, 90, and 105. Now this panel immunophenotype of MSCs are really much more complex than this, but this is just to give you a summary of the markers that have to be present to call these cells MSCs. And then also these cells were considered interested for regenerative medicine because of their ability to differentiate upon specific stimuli into different cell types like adipocytes, osteoblasts, and chondrocytes. Today we know that MSCs are present in almost all the tissues of our body, and we will figure out why in a few moments. But definitely for therapeutic purposes, the most interesting sources of MSCs are bone marrow and adipose tissue. Adipose tissue before 1994 was just seen as a problem because, of course, it was related to obesity and all the related diseases. But then in 1994, with the discovery of the leptin and with the discovery of the metabolic role of the fat in our body, this tissue started to gain some interest into the scientific community. And starting from 2001, this interest further grew because a research group from the US identified a population of MSCs within the adipose tissue with properties that overlapped completely the bone marrow, stromal, or stem cells. So why we should choose adipose tissue? First of all, one of the advantages is that we can isolate cells, or we can exploit the therapeutic potential of adipose tissue through a minimally invasive harvest, for example, by liposuction. Also, there's a high concentration of progenitor cells and MSCs in the adipose tissue, which is reported to be between 50 and 500 times higher than in bone marrow. And this is very important, especially if we choose a one-step technique where we do not grow our cells, we do not make our cells to proliferate. And also important, especially if we treat old patients, there's no strictly age-dependent relationship between the efficacy of the cells and the age indeed of the patient. So this is also important, and that we should keep this in mind, because this is not true for bone marrow. Indeed, it was demonstrated that bone marrow cells as a lower perform less well than in old people, less well than in younger. But like everything, MSCs, they underwent an evolution. So I just told you that we call these cells mesenchymal stem cells because of this property. And their therapeutic potential were associated to their ability to differentiate themselves into cell types to repair or regenerate the damaged tissue. But we observed the shift of these cells. So now we do not think anymore to the MSCs like cells that construct the new tissue, but we consider these cells as cells that manage the reconstruction or the reparative process. And this is due to their origin. So I got a question for you. I know you can't answer me directly, but answer in your mind. So what structure do most of organ tissue have in common? So the answer is blood vessels. And indeed, MSCs have a perivascular origin, and they are a subset of pericytes. So that means that all the MSCs are pericytes, but not all the pericytes are MSCs. And so if you wanna be sure to work with MSCs, we should start from pericytes, which express this panel. So they do not have to express CD34 and CD45, but they do have to express 146 marker. And what do these pericytes do? So when an injury or inflammation occur, the pericytes that usually sleep around the capillaries, they wake up and they start acquiring an activated phenotype, which is called activated MSCs. And they start to produce and then release growth factors, cytokines, exosome, proteins, and peptides with immunomodulatory and trophic effects. And in particular, these cells start to modulate the immune system by decreasing the concentration of pro-inflammatory cytokines and by and also natural killer cells, T cells, and dendritic cells, while increasing the concentration of anti-inflammatory cytokines. So what MSCs do, and the reason why I told you that they manage the healing process is because they interact with the resident cells by terminating inflammation and creating a more receptive microenvironment for the action of reparative stem cells. So we have seen this kind of shift, which is very important. And this shift also has therapeutic implication, which I will describe you soon. So how do these cells work? It's still true that they can differentiate themselves, but especially if we use cells in injective therapies, we cannot expect all the MSCs to reach the defect, for example, on the condyle, and to stack on the defect and start regenerating the tissue. Probably some of these cells will do this, but most of them will actually act through another mechanism, which is the interaction with the resident cells, as I just told you, both through paracrine activity by releasing molecules and extracellular vesicle, but also through a direct cell-cell contact. And for this reason, the acronym MSCs has been changed in 2010 into medicinally signaling stem cells. Right because these cells indeed release many signals, many molecules that actually are also medicinal because are received by the resident cells. And so what we can expect is if we shift this scenario, if we shift our opinion about the mechanism of action of MSCs, what we can expect, for example, when we inject cells into an osteoarthritic joints. The inflammatory environment of an osteoarthritic joint, which is mainly characterized by the presence of inflammatory mediators like TNF-alpha and interleukin-1 beta, will actually wake up these cells that we inject, and they will understand there's something going on in the joint, and they will start producing and releasing molecule with anti-catabolic, anabolic, and anti-inflammatory effects that will be received by the cells of all the tissue involved within the joint, like synovial membrane, cartilage, and subchondral bone. So the therapeutic implication of this is that since the therapeutic function of MSCs is mainly related to the crosstalk with the surrounding resident cells, it won't be necessary anymore their integration and their long-term survival in the site of implantation to promote tissue healing, because they start to modulate the reparative process, which then is continued by the other resident cells. But let's go back to the adipose tissue. So we know that adipose tissue is made mainly by adipocytes, but also, as I told you, we have a percentage of cells that are MSCs or pericytes, which are wrapped around capillaries. We also have pre-adipocytes and other cell types. And all these cells are embedded into an extracellular matrix, which is mainly due by collagen and connective tissue, and surrounded by microvasculature. So MSCs are in a niche, and we call the niche like a stem cell niche. And why it's important to keep the stem cell niche? It's important because these cells, if we keep the stem cell niche, the MSCs pericytes are in their physiological environment. And the importance of keeping stem cell niche has been demonstrated in different studies. I just show you two of them. Here, the cells were isolated from both lipoaspirate, which was treated by collagenase. So the adipose tissue was completely destroyed by the collagenase, and the cells isolated, the adipose stem cells were isolated from the rest of the cells and from the rest of the matrix. And in this case, for the blue line, the cells were isolated from lipogens, so where we kept the stem cell niche. And what we saw is that there's a higher survival in vitro of these cells, demonstrating that these cells are characterized by better properties than the other cells. And also here in this other study, back to 2013, it was demonstrated that in the intact stem cell niche, there's a higher presence of 146 expression, which, if you remember, I mentioned as one of the marker for pericytes. FT stands for fat transfer, which is the same than lipoaspirate. So in this case, it's a tissue which was not treated with lipogens. And in this case, it was treated with lipogens. So removing what we do not need from our adipose tissue, which is what the lipogens device do, and I will show you later on, increase the expression of the cells that we do need for regeneration or repair. And also, if we go even in a little bit deeper into the molecular aspect, in this other study, the researchers found out that microfat were able to produce higher amounts of growth factors and anti-inflammatory cytokines compared with enzymatically dissociated cells, so with the cells dissociated with the collagenase. And this is again because if you keep the stem cell niche, these cells are more in their natural environment and they can work as they are used to do. So if we want to work with the adipose tissue, we can either isolate by enzymatic digestion our cells, and this usually this process takes hours or days, especially if you wanted to culture the cells in vitro, or if you want to be faster, which is of course more easy for the clinical setting, and also if you don't want to go into more complex regulatory pathway, then you can use a mechanical method to obtain the microfermented adipose tissue. And this is exactly how the lipogen device works. In particular, the microfermented adipose tissue that you get using the lipogen device is washed and rinsed, because the cylinder where you put your adipose tissue is actually washed through by saline solution, which remove the pro-inflammatory impurities such as oil and blood. Oil is because blood, of course, it's intuitive why we have blood, because the adipose tissue has a big network of capillaries, but also oil because the shaking of the adipose tissue into the cylinder, which is one of the main steps of the of the lipogens process, bring to the break of adipocytes. And you know, adipocytes are made up to 90% by lipids. So if you break adipocytes, all the oil contained in the adipose tissue will be in your sample. So you don't want this because it's pro-inflammatory. And so washing and rinsing allow you to remove all these impurities. Moreover, through the filter that are placed here and here in the cylinder, you obtain the microfragmented adipose tissue with an optimal viscosity and handling to inject the product. And at the same time, these do not alter the microarchitecture of the adipose tissue, so it does not alter the stem cell niche. And in this way, we protect pericytes and we strengthen their effectiveness in the clinical application. Just a few more slides for basic science, where I want to show you, I want to convince you that lipogens work through a paracrine action, which is what I explained you before. In this study, synoviocytes from osteoarthritic joints were put in co-culture with the microfragmented adipose tissue, and there wasn't a direct contact between the two products. So the synoviocytes were cultured on the bottom of the well, and adipose tissue microfragmented with the lipogems was put into a transwell. So the contact was not direct. They could just exchange molecules. They couldn't touch each other, and despite this, after some days in culture together, the study, the researchers demonstrated that the intact microfragmented adipose tissue, which is this part of the picture, was able to let's say, modulate the pro-inflammatory, anti-inflammatory molecules better than the cells isolated from microfragmented adipose tissue. So again, a demonstration that the preservation of the stem cell niche is important for the function of the adipose tissue. And again, in this study, which is exactly the same culture model, but in this case is in tendon. So I know we are talking about joint, but this is just a cell model which can be duplicated into other tissues. And this is from my research group. We put tendon cells on the bottom and microfragmented adipose tissue in the transwell, so there's no direct contact again. And despite this, microfragmented adipose tissue was able to counteract the inflammation-driven expression of fibrosis and catabolic markers like collagen type 3 and metalloproteinase 1, which were increased by the presence of interleukin 1 beta. And also was able to produce anti-inflammatory paracrine mediators such as EL1 array. So not only counteracting the inflammatory-driven expression, but also to produce an anti-inflammatory response. So now we go to the clinical findings of the joint condition. These data are really up to date because we have just concluded a systematic review on this topic. And we found in literature 23 studies using lipogems, of which 16 about injected treatments and 7 about the surgical use of lipogems. 5 of them are randomized controlled trials. 2 report quantitative radiological data through the DGEMRIC protocol, and 7 of these studies include more than 90 patients each, for a total number of patients of almost 1,700. So I think that for this kind of product in the orthobiologic field, this literature production is impressive and has probably no competitor at the moment. Moreover, in literature, you can also find 30 in vitro or basic science studies that support and confirm the clinical findings. So I can, of course, I don't want to show you all the 23 studies. I will just show you the most significant, but you are definitely welcome to ask for the entire literature production if you are interested to read it. This study has been published yet, so you are probably, the first to see this data. It has been conducted by the group working at the Rizzoli Hospital in Bologna. They found that lipogem injection allows stable and significant improvement in osteoarthritic patient up to 2 years. And it was a randomized controlled trial versus PRP on 108 knees. And the study demonstrated that lipogems perform significantly better at the last follow-up than PRP, especially in Kegler-Lorentz 3-4, where the difference was significant. Also, at the lower degree, we have better improvements in MFAT. As you can see here, for a PRP, we have a decrease of the performance, the decrease of the clinical outcome in the patient treated with PRP, while we have a stable outcomes in the MFAT patients. But this difference is not fully significant, but here it is. In this other study, again, a randomized trial versus PRP, in this case in 18 knees, the results say more or less the same. So lipogem injection significantly improve the clinical outcome of osteoarthritic patient at 1 year and perform significantly better than PRP in terms of Tegner activity scale. So that means that the patients were able to go back to their activity in a more efficient way when they were treated with the MFAT rather than with the PRP. This other study is one of the two I mentioned that reported quantitative data. Indeed, the authors not only assessed the patient with the classical prompts, but they also evaluated the GAG increase, the glycosaminoglycan increase, following an injection of lipogems. The study was conducted on 32 knees, and the authors of the study reported that not only there was a significantly clinical improvement in the patient over time, but also they saw that the injection of adipose tissue actually produced a new extracellular matrix that was significantly closer to the native cartilage than at the baseline. So the injection of MFAT actually influenced the structural and biochemical changes of the cartilage. And I think this is a really important finding, because very often all the studies claim for no quantitative effect of the orthobiologic injection, because indeed also in this study they did not see an increase in the cartilage thickness, but they saw an increase in the cartilage quality, and with a regular MRI also in T2 is not always visible. So with this protocol, which is aimed to assess the quality of the cartilage, they were able to find this. And in this other study, which is very similar, it's in this case at 2 years, and again improvement in pain in the osteoarthritic patients treated with MFAT, and also again confirmation of the increase of the content of the in GAG. In this other study, which is not a randomized study, but it's a huge case series, including more than 400 patients, the authors saw significantly improved clinical outcome, especially in terms of pain in patients treated with an injection of lipogems at 2 years. And since they had such a big case series, they were able also to discriminate patients according to gender, and they saw that female had superior improvements than male patients. And this is also and this is true for both VAS and also for OKS. Also, in this other study from a group from the UK, the lipogems injection was reported to significantly improve the clinical outcomes at 2 years follow-up, again in osteoarthritic patients. And in particular, it works better in the most severe cases. So these data actually are confirmed by the other study that I show you at the beginning from the Rizzoli group, where the most severe cases respond even better than the others. And also the same group published another case series where they show significant improvement in this patient at 1 year follow-up. And in this case, they did not assess any difference between the OA grade, so no differences in terms of OA grade. This is another study which is not submitted yet. So again, this is brand new data. This group is from Italy, from Professor Zorzi, and they demonstrated in a large case series, in this case it's more than 200 patients, that with the Kegler-Lorentz from 2 to 4, that lipogem injection significantly improved the clinical outcomes at a very longer follow-ups, because some of these patients were assessed at 3 years. So this is really impressive. I think the stability of the improvement, it could be maybe obvious for you that it works at 6, at 12 months, maybe at 24, it's also obvious, but 36, it's, in my opinion, is quite impressive, especially if we think that these treatments, as I described you in my previous slides, works through the restoration of a regenerative environment. So that's really impressive, I guess. And very interested also that along the study period, only 16% of the patient had additional injections, and only 6% with 3, especially percent of the patient needed the total joint replacement. Also, it's very interesting that at 12 months, almost 50% of the patients who were used to assume painkillers discontinued these drugs. And again, the significant improvement which I just mentioned you at 12, 16, and 24 months. And I think that's my last slide for clinical study, if I'm not wrong. No, the one before the last. Because here, the study I just presented you were for the injective treatment of lipogems. Here we moved to the use of lipogems in surgery. So in these cases, the authors treated focal chondral lesions with lipogems together with microfractures in this randomized controlled trial versus microfractures alone in 24 patients. And the results show that when lipogems was associated to microfractures, the results were better. And moreover, also the satisfaction of the patient was significantly improved in the patient with which received the complete treatments. And in this study, again from the group in Verona, Italy, this study is pretty is one of the first. Is a pioneer, is a pioneeristic work. In this prospective case series, they treated 30 patients which were treated for different kind of surgery, and they associated the lipogems in this procedure, always for joint degeneration, and they saw an improvement up to 36 months with respect to baseline in all these cases they evaluated. Of course, the significance of adding lipogems is not possible to assess the significance because there's no control group, but the authors claim for better results than their historical cases when they treated the same kind of patient with the same procedure. But of course, it's not really a direct comparative study, but it's probably significant, and I wanted to report it because it's interesting, the longer term follow-up. Before going to the conclusion, I want to mention the adverse event in the study, because sometimes orthobiologics are associated to adverse events. I want to share with you that in almost 1,200 patients and more than 1,400 treated knees, we had no severe adverse event. Mild adverse events were reported at the harvest site in a very different percentage, up to 50% in some studies. But when we say mild adverse event, could be also hematoma of the belly, for example, which is quite normal if you perform a liposuction. And also mild adverse event at the injection site were reported in a very low percentage along the studies. And in any case, most of these events resolved shortly, less than 3 days, while the other lasted up to 1 or 2 weeks. Just briefly want to mention that lipogens can be applied to other clinical settings. So we have just mentioned, I talked about joints and in particular knee, but it can be used also for hip, for shoulder, and also for tendinopathies. We are running here in my institute a clinical study on the use of lipogens for partial rotator cuff tears, and also non-orthopedic application. And in particular, there are really tremendous results in advanced wound management, especially for the diabetic foot chronic ulcers, for the colorectal surgery, especially for the Crohn's disease, and also in gynecology applications. So if you are more interested, you can get maybe other information through Victor. So my conclusion is that adipose tissue is definitely a versatile tool for regenerative medicine or reparative medicine, because adipose tissue has been demonstrated to have an evident role in both conservative and surgical orthopedic treatments. Cell therapy-based treatments respect the tissue physiology while enhancing the natural healing process, and therefore none of these approaches impede further treatments. If you want to exploit the adipose tissue potential, lipogems is definitely a practical and efficient way to do it. Lipogems device is easy, approved, safe, and effective in both intraoperative procedure and surgical procedure. It's compliant with the regulatory and technical feasibility. As I show you, there are solid clinical results in terms of pain and joint function, because they are very consistent among all the available reports, demonstrating its efficacy at least up to 24 months, but we think beyond, as I show you also in the last database from the group of Professor Zorzi, especially when used as conservative treatment. And also, very important, lipogen device demonstrated a high safety profile and high level of patient satisfaction. So thank you very much for listening, and I'm definitely happy to answer your question if you have it. Thank you very much.
Thank you very much. Thank you, Laura, for covering biological plausibility on that exciting topic. How good is it to take someone's unwanted fat and use it for something to improve the quality of their lives? So we've got some questions, quite a few questions actually. Let me ask you, well, first one, are you able to share the presentation with the attendees?
Yeah, sure, of course.
Fantastic.
Yes,
all right.
Absolutely.
I'll get it off you and I'll forward it on to you.
Yeah, I will send to you and you can share it, of course.
Okay, so does the omega-3 index or quality of adipose make a difference to the quality of the MSCs?
That's an interesting question. Actually, there are no studies also in the basic science, I mean, assessing the differences in the differences of adipose tissue in terms of differences in clinical outcomes or in terms of quality of the MSCs. We studied the difference between the obese adipose tissue from obese patient and non-obese patient, and we saw that especially the hypoxia, which characterize the adipose tissue of obese patient, impair the properties of MSCs. But this is the only knowledge I have about it. I don't know exactly about the omega-3 index. I'm sorry. It's interesting. It might be interesting to explore it further, but I have no clue, honestly. But definitely, adipose tissue are not strictly age-dependent. The features of adipose stem cells are not strictly age-dependent, as I mentioned, but there are other parameters that can influence the adipose tissue performance, the adipose tissue cells performance. In particular, as I mentioned, the obesity, also the use of some drugs can impair the adipose tissue properties. Lifestyle like smoking or drinking is also affecting this, but there's no studies which brings definitive conclusion on that. We know there's something happens, but we do not know the clinical, let's say, consequences about using these cells.
Is the treatment indicated for meniscus and articular cartilage?
Yes, articular cartilage, definitely, because we performed a nice study. I didn't show you because I didn't want to be too basic, but of course the molecules released by adipose stem cells, which are injected into a knee joint, are received by the cartilage cells. And we performed this study with a very advanced technology where we could see that the microvesicle and the exosomes released by the cells, which are actually like a pool of molecules, are actually incorporated into the articular cartilage cells. And this is clearly seen by the by this technique we use, which is a technique which is coupled with the confocal microscopy. And so definitely this treatment is indicated for all the joint, including meniscus. Yes, we have proof in vitro, and we have proof in clinically in this in the paper that are reported in literature. I didn't mention, for the sake of time, there's a study where they injected both intraarticularly and intrameniscal because the patients were all with meniscal problem. And maybe, Victor, I can share with you this article, and it might be interesting for Julian, who asked this question. Yes.
Okay, all right. And could you please explain the experiments where substrates weren't touching but had an effect?
Yeah, sure. Maybe if you don't mind, I will share again the slide because you can see the picture.
Okay.
It might be easier. So let me go to that slide. I will go to mine. Okay. So in this, it's called a transwell system. So here on the bottom of the well, you have the target cells. In this case, we had tendon cells. And here in this transwell, actually in this insert, we had the autologous microfermented fat. And so they are not able to touch directly. The only, let's say, interaction is through the release of paracrine signals, because they cannot be cell-to-cell contact. And despite the lack of cell-to-cell contact, the let's say features of tendon cells were affected by the presence of autologous fat. So when the tendon cells were cultured in presence of adipose tissue, they were able to counteract the inflammation driven. So here we evaluated the presence of collagen type 3, which is associated with fibrosis. And in this case, the cells actually, when were treated with interleukin-1 beta, were show higher level of collagen type 3. And also, as you see here, tendon cells alone were, and tendon cells plus the inflammatory molecules, interleukin-1 beta, express higher level of metalloproteinase 1, which is associated to matrix degradation. When we treated these cells with microfat, you see that the level of this marker goes down again. So here the fibrosis marker, collagen type 3, and here the metalloproteinase 1, with respect to the inflamed cell. So this is the effect in counteracting the inflammatory driven expression. And also, not only counteracted, but they produce anti-inflammatory paracrine mediators by producing, when microfat was added, interleukin array, which is known to be acting in response to interleukin-1.
Is it approved in Australia? And the answer is yes. Once the TGA approved it, it's been approved by most regulatory bodies around the world, in Europe, America, China, South Korea, etc. And now in Australia, the TGA has approved it. And so now this can be used to treat patients in Australia. So, and one of the reasons why I think it's important, you mentioned, Laura, homologous, and the TGA was asking about in the application for this, that this is a homologous type closed loop system as well. So they were wanting to know that the transplanted cells are characteristically and functionally the same as the destination cells, and that was very important for the regulatory approval.
Yeah, definitely.
All right. Okay, let's see what other questions. We've got a couple other questions here. What joints can be treated with? What about rheumatoid arthritis? Is this an option for rheumatoid arthritis? Or is it osteoarthritis mainly?
Yeah, I mean, the current knowledge is about osteoarthritis. There's no evidence in rheumatoid arthritis, although orthobiologics are gaining more interest among the rheumatologists, because there's room for their efficacy and there's room for their application. But especially with lipogens, we do not have any finding at the moment.
Okay. All right, here's another scientific question for you, Laura. How far a distance between the cells have you observed that paracrine signaling still works? Background, context, quorum, sensing of cells.
Yeah, I got the question. It's interesting. So in the model I show you the distance between the macrophage and the cell layers was probably a couple of millimeters, but that's not the limit for the cell. So as long as you have enough high concentration of mediators within your liquid, within your culture medium, then the distance is not so important, because the concentration, these molecules actually diffuse through the culture medium, and they reach the cells no matter the distance. So of course, in an in vivo environment where you inject something in a knee, for example, the presence of big amount of synovial fluid, especially in a swelling knee, could dilute the effect of these molecules and could somehow limit the journey of the molecules to the cells, and that's why also in the consensus recommendation guidelines that were provided by the expert group here in Italy, they suggest to, in case of swelling knee, to remove the synovial fluid, the abundant synovial fluid, before injecting the knee.
How can I get involved? I might answer that question. Well, for a start, just contact us. If you're a doctor, there's options to treat patients or refer patients. There's training available in Australia as well. And if you're an allied health professional, there are opportunities to provide post-op care for patients, like exercise and weight loss as well. And look, I've got Dean as a panelist who's got a lot of experience in that area. You might want to add a little bit there.
Yeah, I mean, I've got, it's interesting here in Australia, we haven't been able to see too much clinically, but a good number of sports physicians have utilised some of these restorative techniques in the past. I've been involved in various iterations from stromal vascular fraction, or using enzymatic digestion, all the way through to lipogems and even culture expanded mesenchymal stem cells. I think clinically, and when we get to work with various clinicians, you know, the doctor's not just treating a joint, they're treating a whole patient. So it's important to look after the nutritional environment of that patient as well, especially when we did get to harvest the tissue and isolate MSCs. We did notice if the patient was on an anti-inflammatory style diet prior to tissue harvest, their stem cells seemed to look better under the microscope and grew faster. But more importantly, we get to reintegrate back into a better biochemical environment. And, you know, we know that obesity and being overweight is a major risk factor for these types of degenerative joint disorders. So it's important to handle that as well, and especially in the context of hyperinsulinemia, which is the biochemical environment that causes weight gain. So, if, you know, you've got to put the fire out, because the hyperinsulinemia is what's driving the the inflammation up. And we know that in the metabolically deranged, there's inhibition of chondrocyte maturity. There's a suppression of collagen production, and in a background context of high insulin and inflammation, sometimes the chondrocytes lay down the wrong type of collagen 10 generally instead of collagen 2. So, if you can handle metabolic health and as well as these restorative techniques, it has an even bigger impact on the patient, what I've observed.
Thanks, Dean. Another one for Laura or the LipoGems team. What's the future of LipoGems? What will we be treating in 3 to 10 years' time?
Oh, I think this is maybe more for Giovannino or Raffaella.
Yes. Well, there are studies going on at the moment about LipoGems use, adipose tissue used in advanced therapy. So at the moment we are not advanced therapy, we are tissue transplant, and the treatment is completely autologous. But of course we've been, not only us, but scientists in general have been studying the use of adipose tissues in other areas. And there is a study going on at the moment on done by a veterinary surgeon, a vet, on LipoGems used as scaffold for drugs, drugs for dogs' tumors, and results are encouraging. Of course, the path is still a long one at the moment, but we do think that the future is probably advanced therapy, and also the allogenic use of LipoGems, of adipose tissue. And then, of course, other applications, as Laura told you, like we have amazing results in LipoGems used in fistulas from Crohn's disease, non-responding fistulas. So it's a it's quite a rare illness, and also very good results with recent studies published on diabetic foot ulcers. And so we are confident that we have a long way to go on these other applications of LipoGems. We will keep you posted.
Okay, fantastic. Question, how is this different to Regenokine? If anybody knows the answer to this, or other types of treatments?
Regenokine, I think, Vic, is a blood product, sort of a more advanced version of PRP, or a refined version. I believe similar, it might be the same as orthopine, where they use some glass beads and heat the blood product.
Right.
Yeah, so it's different product altogether.
Okay, cool.
If I may, it's of course it's different because of the source. One case is blood, in one case is adipose, but also it's different because all the blood-derived products actually you get what you get. So you prepare your PRP from the blood patient in that moment, and that's what you are going to inject. And there's molecules there which derive from what the patient had in that moment in his blood, or in her blood. If you use cells, cells sense the environment and they react accordingly. So it's just like they are more versatile, they're more adaptable. So with PRP, you may be very lucky, and in that moment, your patient has a very good, a very high level of anti-inflammatory cytokines or high level of growth factors, but you may be not so lucky and your patient not be so performant at the moment. With the cells, you have more opportunities because the cells actually respond to the environment. So that's, I think, it's also a big difference between cell-based therapy and all the blood-derived products.
Okay, so is there any opportunity, a question here, any research on both LipoGems and PRP synergy?
Yeah, no, that's very, very interesting. And also it's something that a different level people are investigating. We do not have experience of lipogens plus PRP. As I show you, we have evidences about lipogens versus PRP. But the other in literature, I read papers where they combined other products other than lipogens with PRP, and the effect seems to be a little bit better with PRP. But in our opinion, or at least my opinion, I think, of course, it makes sense. And also in vitro, if you add PRP to adipose stem cells or lipogens as it is, you get very good results, because PRP is, we know, it's rich of growth factors, it's rich of orthotrophic molecules. So it's just like feeding your cell with something. But we do believe that lipogens alone can be also enough to exploit the function we want to achieve, and especially in the clinical setting, adding additional cost just to get maybe plus 1% of performance may be not worth.
Exactly.
Okay. Well, thank you, Laura. We're out of time, unfortunately, and as I promised, we would keep this within the 1 hour. So look, there's more questions that we haven't answered yet. So can I suggest we will send out the answers to these questions and more after this event. If you have any other questions, if you think of anything after this presentation or this session, please send them through, and we'll come back and provide you the answers and the presentation, and we'll endeavour to get you a copy of this video as well. All right, so thank you very much. Panelists, is there any final comments from any of the panelists? We good?
I just thank you to you, Vic, for helping to make this kind of approach available here in Australia. I think it's great.
Thanks, Dean.
Also, many thanks to Victor and the organization, and of course, thank you very much to Laura.
Thank you, everyone. It was a pleasure for me. Good night there. Here for us is still morning.
Yeah, good night.
Good night, everybody.
I'm jealous you can go to bed. You cannot.
Me too. Me too.
Okay. Thank you, everybody. Good night.
Thank you.
Have a good
Thank you,
day.
everyone. See you.
Bye.
Bye-bye.
Good night. Bye.